Good afternoon or good morning, everybody. Season's greetings and welcome to our webcast today on the CAHPS Child Hospital Survey, using database results and new narrative items to guide improvement. My name is Dale Schaller. I'll be your moderator today for the webcast presented by the Agency for Healthcare Research and Quality, or AHRQ, CAHPS User Network. Next slide, please. We have just a few housekeeping details to review before we get started. First of all, if you have any trouble with your computer audio, you can connect to the webcast audio using your phone by clicking phone call and finding the dial-in number and the meeting ID, or you could select call me and have Zoom call you back with your phone number. If you have any trouble with your computer freezing up during the presentations, you can always try logging out and logging back in. And at any point in the webcast today, you can ask a question, and we encourage you to do that by using the Q&A icon. And we encourage you to do that by sharing your name and your organization affiliation so we know a little bit about who you are. We will address all of the questions at the end of the webcast, and we hope to get to all of your questions before we conclude. One important note, because this is a question that always comes up, we do have the slides available for today's webcast on the event website for the webcast, which is noted here on your screen. It's at events.westat.com/CAHPS/webcast. And that event site, which was included in your registration confirmation, includes the presentation slides, the agenda, as well as bios to each of our speakers. Next slide. So our agenda today will begin with a brief welcome from the Agency for Healthcare Research and Quality, followed by an overview of the CAHPS Child Hospital Survey, which is also referred to more simply as Child HCAHPS. We'll then turn to a description of the Child HCAHPS Survey database, which is now in its second year, followed by an overview of the new narrative item set developed for use with Child HCAHPS, as well as other pediatric inpatient surveys. And we hope to, as I said, leave as much time as possible for your questions before we conclude the webcast. Next slide. So we're very pleased to have a stellar lineup of speakers to guide us through today's agenda. They're popping up on the screen now, so you can see their images. To start us off, we have Jonathan Bakdash, who serves as a social science analyst for the CAHPS and Survey of Patient Safety Culture Program, or SOPS, with the Agency for Healthcare Research and Quality. John will be followed by Sara Toomey, who is the Chief Experience Officer and Chief Quality and Safety Officer at Boston Children's Hospital. Sara will be followed by Teresa Dodson, who is the CAHPS Database Manager at Westat. And we conclude with Stephen Martino, who is Senior Behavioral Scientist at RAND and a lead investigator on the CAHPS Narrative Research Team. And again, my name is Dale Schaller. I'm a member of the CAHPS team, and I'll be moderating today's presentations. So with that, I'm very pleased, Jonathan, to turn it over to you.
Thank you very much, Del. I'd like to welcome everybody. Thank you for joining us today. I'm going to give a brief overview of AHRQ and some general background information about the CAHPS program. The CAHPS program stands for Consumer Assessment of Healthcare Providers and Systems. For new users, we want to provide an introduction to the CAHPS program. For all users, we'll be presenting results from the Child HCAHPS Survey and also cover a new addition to the CAHPS program for evaluating patient experience narrative items. Next slide, please. So AHRQ is a science-based agency. We invest in research and evidence to make healthcare safer and improve healthcare quality. We create tools for healthcare professionals to improve patient care. We also measure and collect data used by providers and policymakers to evaluate progress and improve performance of the U.S. healthcare system. Our aim is to move science to implementation and to get our tools and products to users. And AHRQ has several core competencies: health systems research, practice improvement, and data and analytics. And all of these are about improving healthcare quality and safety, creating tools and being able to measure this. So AHRQ is not a regulatory agency. AHRQ does not require use of tools, products, and our databases. There is no federal requirement from AHRQ to use the Child HCAHPS survey or any CAHPS survey. It's strictly for your own quality improvement purposes. Next slide, please. So CAHPS surveys assess patient experience, and I'd like to briefly define patient experience. There are a number of domains, and patient experience assesses what actually happens to a patient in a healthcare setting or health plan, or how often something happens. It's interactions that patients have with the healthcare system, with healthcare providers, and this slide shows some of the domains here for patient experience. And these are just some of the examples, including care coordination, communication with clinicians, getting information. And the most critical thing that I want to mention here is patient experience is different from patient satisfaction. Although they're often used interchangeably, patient experience is about what patients actually encounter in healthcare, whereas patient satisfaction is expectations and whether or not expectations were met during healthcare. Next slide, please. So CAHPS surveys are considered a gold standard for patient experience measurement because they reflect what patients told us is important to measure. And during the development process for CAHPS surveys, this is patients tell us this, and this captures the patient's voice. CAHPS surveys use a standardized methodology for development, validation, and revision. And there's extensive testing with patients to make sure the questions are relevant and understandable, that patients understand the items on the survey and they feel they're relevant to their experience with the healthcare system and healthcare providers. Next slide, please. So this gives you a sense of the CAHPS universe. There are a number of different CAHPS surveys, and you can see from the puzzle pieces here, it includes experience with providers, experience with facility-based care, and today we'll be focusing on hospitals and pediatric. This also experience with health plans and experience with condition-specific care. And this shows some of the CAHPS surveys focus on condition-specific care, whereas today we're focused on facility-based care. And this just gives you a sense of the variety of CAHPS surveys. Next slide, please. And here are essential uses for the CAHPS survey. Probably first and foremost is for quality improvement. If you're not measuring it, it's very hard to assess where you are with patient experience. Some other purposes include public reporting of information, certification and recognition, value-based purchasing, and also for health services research. The next presentation by Dr. Toomey is going to cover an overview of the Child HCAHPS survey, in addition to some case studies for quality improvement use. Next slide, please.
Hi, how are you? I'm really happy to be here today to speak with you all. I am, as was said, my name is Sara Toomey. I'm at Boston Children's Hospital. I'm the Chief Safety and Quality Officer and Chief Experience Officer here, in addition to being the PI and Director of the Center of Excellence for Pediatric Quality Measurement that's based out of Boston Children's and funded by the Agency for Healthcare Research and Quality. I'm going to start by just speaking at a very high level about the Child HCAHPS survey items. This survey was developed in 2015 by our center at Boston Children's as part of the Pediatric Quality Measures program. This is a survey that is for parents and guardians. It's on their report of the inpatient care experience of their child, ages 17 and under, who have been hospitalized for a whole number of different care. There are 18 single item and composite measures within the survey that fall under 5 overarching groups: communication with parent, communication with child, attention to safety and comfort, hospital environment, and hospital rating. To tack on to what was just said, Child HCAHPS was very rigorously developed, and you can find more information on the AHRQ website. at www.ahRQ.gov/CAHPS/surveys-guidance/child_HP_survey.html. To just briefly summarize, extensive formative work was done in this development process, in addition to qualitative analyses, both with focus groups, in addition to a series of cognitive interviews. We then did an extensive field test, which I'll be showing you some data from in just a moment, and ended with additional sort of user interviews to make sure that we were capturing sort of adequately the experiences of our families as they are thinking about their child's inpatient care. We just go to the next slide. So here's an example of the measures that are within Child HCAHPS. So this is from the national field test. There were 69 hospitals that participated throughout the country. The overarching areas are listed listed on the left. So communication with parent, communication with child, attention to safety and comfort, hospital environment, and hospital rating. Within each of those areas, there were a number of questions and composite measures. And these are some examples. So within the communication with parents, there is a composite measure of keeping you informed about your child's care. When you then look to see what the average hospital top box score was across those 69 hospitals that participated, it was 72%. In regards to how well nurses communicate with your child, that average top box score was 70. Preventing mistakes and helping you report concerns, top box was 56%. Quietness of the hospital room, 63%. And the average hospital top box score for overall rating was 75%. So as you can see here, what we were able to demonstrate through this national field test is there's definitely room for improvement across the board in many areas that are very important to patients and families. What this slide, which is also from the national field test, demonstrates is what it's looking at. Each of the bars in this bar graph represent one of the hospitals that participated in the national field test. And this is what this is it's the top box score for each of those hospitals for overall rating. And what we're demonstrating here is that not only overall is there room to improve, there's actually a fair amount of variation across hospitals in regards to the overall rating of care that they're providing. And this difference that you see is actually statistically significant. Should say that dotted red line represents that average top box score that you had seen in the slide prior. What I think is really important is sort of how are we to use Child HCAHPS? So one of the things that we've done is we have created a toolkit that actually helps hospitals think about how they can use Child HCAHPS to not only measure, but also enhance dimensions of care. In particular, these fall into these four categories: improving communication with providers, preparing families for discharge, engaging with patients and families to improve pain management, and improving overall willingness to recommend. And all of these, this toolkit with the highlights for different quality improvement cases can be found once again on the AHRQ Child HCAHPS website.
Access case studies at www.ahrq.gov/PQMP/toolkit/child-hyphen-HCAHPS/index.html.
What I wanted to do is spend a little time walking through 3 different case studies. Once again, just to demonstrate, and all of this is published work, about how people are using Child HCAHPS to make meaningful changes within their organization. So this first case is in improving communication with nurses. So the goal of this project was to improve Child HCAHPS nurse-child communication scores to be above the 75th percentile. What they did in regards to their intervention is they implemented a communication bundle that included bedside nurse shift reporting, whiteboards, and scripting. And to see whether or not their intervention made a difference, they looked at outcome measures from Child HCAHPS. In particular, they were looking at two communication items: how often the nurse listened carefully to the child, and how often the nurse explained things in a way that was easy for the child to understand. What you can see in these two graphs are the results of their study. So on the top is the measure of nurses listen carefully to the child, and on the bottom is nurses explain things to the child. What you can see here is prior to the intervention being started, you can see that at that point in time back in FY16, their results for both of those were quite low. After these interventions were put into place, what you can see is their scores increased substantially, and they were able to reach their targets of being greater than the 75th percentile. The second study I wanted to highlight is around improving pain management engagement. So here, the goal of the study was to engage patients and families in conversations about pain management to improve effectiveness of pain treatment. The intervention here was interactive patient care technology and also a new pain assessment workflow. And they looked specifically at the Child HCAHPS question of, did staff do everything they could to manage your child's pain? What you can see on the right-hand side with the bar graph are once again looking over time. And in this case, they're looking at three different units. Two different units. And on the right side is actually the aggregate. So on the right series of bar graphs is the hemonc and also the medical surgical units aggregated. And what they were able to demonstrate is that there was a statistically increase on their scores from 75.3 to 83.3 on the aggregate, and that in particular in their hem-onc units, they were able to show an even greater improvement. And that's the bar graphs on the left, where they went from 62.9 to 85% top box scores. This last case is more recent, and I think is really interesting in once again driving care. And in particular, this is addressing some disparities that were noted by UCLA. So in this case, they were trying to improve communication, in particular for Spanish-speaking families. So what they wanted to do in particular is focus on family-centered rounds. And the intervention that they put in place was to implement simultaneous in-person interpretation of family-centered rounds for Spanish-speaking families. And they looked specifically at a number of Child HCAHPS communication and informed care measures. What I've done here is selected a number of those. And as you can see, I'm going to walk you through their results. So in regards to how often did child's doctors listen carefully to you, their Spanish top box score before implementing this intervention was 63%. And afterwards was 95%. And this is in comparison to English top box scores that remained stable. Went from 85% and actually decreased to 80% in the post-implementation period. The differences that you see here were statistically significant. These findings were replicated in a number of their measures. So here again, and how often did child's nurses listen carefully to you? You see a meaningful difference, 63% to 92% post-implementation. We're seeing the same findings again when you look at how often did providers keep you informed about what was being done with your child, for your child. 63% to 88%. And once again, flat in regards to their English-speaking patients. And lastly here, how often did providers give you as much information as you wanted about the results of tests? Here went from a low of 41% up to 71%. And once again, this is flat or even a decrease for their English top box scores. While this is not all of the measures that were included in this study, and not all of them admittedly were statistically significant, I think this really demonstrates how child HCAHPS can be used to make meaningful differences for populations of patients. So I wanted to take a moment and just talk about what some of the benefits of participating in the AHRQ Child HCAHPS database. This is the first comprehensive database for child HCAHPS. I think as many of you are aware, as pediatrics are not required in the same way to be reporting in for Medicare, such as for the adult HCAHPS. Child HCAHPS has not been able to be aggregated in a similar manner. So this database is presenting a real opportunity for all of us to be able to take a look at our scores against other hospitals throughout the country. In addition, this is a free resource that's available to all survey users. And the importance here is that it doesn't matter which survey vendor you are using. It doesn't matter, you can obviously be sending in your results for many different sort of modes of use. And so here again, we are changing often our survey vendors as we are trying to compare ourselves to different hospitals for which they have different survey vendors that they use. This becomes really meaningful. I also want to take a moment and speak a little bit about the importance of case mix adjustment for meaningful peer comparisons. So I think many of us who are using child HCAHPS do get some comparative data from our survey vendors. This comparative data, for the most part, at least that I am aware, is not case mix adjusted. And why this is so important is that it really allows us to do our best to adjust for those aspects of the individual patients and respondents that we think are contributing to the scores, to allow for us to better adjust across hospitals to understand how we're performing. I also want to just state that this database allows us to look comparatively across our hospitals and identify opportunities for improvement and also track progress over time. Lastly, in pediatrics, we've often suffered from the fact that we have not had large, robust patient experience data sets to be able to do research on or to be able to potentially link to other important quality measures. And participation in this database allows us opportunities for research that will be able to help promote meaningful changes in patient experience across our country. Now I'm going to be turning this over back to Dale and to Teresa. Thank you.
Thank you, Sara. Hello, my name is Teresa Dodson. I'm the CAHPS Database Manager, and today I would like to talk about the Child HCAHPS Database resources and a few of the results from the most recent Child HCAHPS Chartbook. Next slide, please. The CAHPS database is a central repository of data from the Child HCAHPS Survey, the Health Plan Survey, and the Home and Community-Based Services, or HCBS Survey. The database is designed for two major applications. The primary purpose is to facilitate comparisons of CAHPS patient experience survey results by and among survey users to assess performance. The database also provides de-identified data for research purposes. The database is funded by AHRQ and administered by Westat through CAHPS User Network. Next slide, please. Participation in the CAHPS database is voluntary and free, and submission is open to all users of the surveys that are supported by the database. Data submissions and reporting for each survey are on an annual cycle. Submitters complete a data use agreement, which assures data privacy and protection. And all results are aggregated and are also de-identified, so no organization-specific data are ever publicly reported. Next slide, please. The CAHPS database produces 4 distinct products. The AHRQ Data Tools website at datatools.ahrq.gov is a website where users can view, print, and download reports of results from the CAHPS health plan and clinician and group surveys, and Child HCAHPS and HCBS data will be released on the portal in 2024. The CAHPS database also produces private feedback reports, which are only provided to database submitters. These feedback reports compare submitters' CAHPS survey results to results from the overall database. There are also annual CAHPS database chart books on the CAHPS website for the Child HCAHPS, health plan, and HCBS surveys, which display summary level results from the databases, and research data sets that are de-identified data files that can help researchers answer questions related to experience of care. All of these database products are free and available on the AHRQ, CAHPS, and Data Tools websites. I will touch on these database products throughout the presentation. Next slide, please. Today, I'll be focusing on the Child HCAHPS Survey database. The Child HCAHPS Survey database is free and open to all users of the Child HCAHPS Survey, which includes freestanding, self-governing children's hospitals within a larger hospital, and pediatric units within a hospital. We just completed our second year of data submission and reporting for the Child HCAHPS database, with 2022 being the pilot year. Next slide, please. Next, I would like to talk about the benefits to hospitals for participating in the Child HCAHPS database. This slide shows an example of a private Excel feedback report that is provided to submitters upon request. The private feedback report shows how a particular hospital performed compared to the overall database averages, as well as how the hospital performed the current year compared to the previous year. So if we look at the first item, communication between you and your child's nurses, you can see that this is a composite measure which has more than one survey item. In the third column, you can see that the database average top box score is 86%. And in the next columns, the specific hospital's top box score is 85% in 2023 and 84% in 2022. This feedback report allows the hospital to identify its strengths and areas for improvement in patient experience. The results can also be used to evaluate whether patient experience improvement initiatives and practices have improved patient experience. Next slide, please. Another benefit of participating in the Child HCAHPS database is that it makes de-identified patient experience data available for research purposes. Researchers can request de-identified data files from the CAHPS databases. These research data set requests are then reviewed, and de-identified data are provided for approved research projects. De-identified data files can help answer important health services research questions related to patient experience of care as measured by CAHPS surveys. Next slide, please. AHRQ produces a Child HCAHPS database chart book with infographics that display aggregated results from all participating hospitals. The chart book contains bar charts for each measure, details on respondent characteristics, and analyses of results by selected hospital and respondent characteristics. Next slide, please. Next, I would like to talk about some of the results that can be found in the current Child HCAHPS chart book. The 2023 Child HCAHPS Survey database results were released in October 2023 and contains 8,107 survey responses that were voluntarily submitted by 35 hospitals. Again, this is just the second year of the database following our pilot tests last year, and while it takes time to build participation, the value of the database really depends on expansion of hospitals submitting. Next slide, please. Looking at the overall Child HCAHPS database results, there were two high-scoring measures reflecting positive patient experiences. The communication between you and your child's doctor composite measure, where 86% of respondents reported that doctors always listened carefully, explained things clearly, and treated parents with courtesy and respect. Doctor communication is a high-scoring measure that we typically see in the CAHPS surveys. Another high-scoring measure is the single-item measure, privacy when talking with doctors, nurses, and other providers, where 85% of respondents reported they always had privacy when discussing their child's care with doctors, nurses, and other providers. Next slide, please. Two low-scoring measures reflecting less positive patient experiences are the preventing mistakes and helping you report concerns composite measure, where 61% of respondents reported that providers always check their child's identity before giving medications and told them how to report mistakes. This is an important finding since patient safety is a measure of increasing focus in hospitals today. Another low-scoring measure is the single-item measure, quietness of hospital room, where 64% of respondents reported that the area around their child's hospital room was always quiet at night. Next slide, please. The Child HCAHPS database consists of data from 8,107 survey respondents who were parents or guardians of pediatric patients aged 17 and younger. A few characteristics of the pediatric patients are that 47% were female, 28% were less than 1 year old, and most were in very good or excellent health as reported by their parent or guardian respondents. A few of the parent or guardian respondent characteristics are that most were the mother of the child, 42% were between the ages of 35 and 44, and 56% had a 4-year college degree or more. Next slide, please. When looking at the results by length of stay, for the majority of the Child HCAHPS patient experience measures, a longer length of stay is associated with lower patient experience scores. When looking at the results by the age of the child, patient experience scores tend to be higher for children over 1 year old. As more hospitals submit to the Child HCAHPS database, we hope to have the opportunity to explore additional analyses of the data, looking at percentile scores, trends over time, and other characteristics. Next slide, please. The CAHPS Child Hospital Database submission will be open March 11th through April 12th, 2024, with the survey administration period between January 1st through December 31st, 2023. Again, participation is voluntary, free, and open to all users of surveys supported by the database. Next slide, please. Hospitals interested in submitting data just need to complete 4 easy steps. Step 1, register for an account where we ask for some general information regarding the hospital. Step 2, the hospital needs to provide a signed data use agreement, which specifies how the data will be used and stored. Step 3, the hospital needs to upload a copy of the survey instrument used, where it is reviewed to ensure it adheres to CAHPS standards. And step 4, the hospital survey vendor needs to provide a data file that has been formatted to CAHPS database specifications. Next slide, please. The CAHPS database team at Westat offers free technical assistance with data submission issues, responding to questions regarding data specifications, and the data submission process. We also offer assistance to any user with our public reporting products, such as use of the AHRQ Data Tools website and how to obtain and use research data sets. The CAHPS database team can be contacted at the email address CAHPS, that's CAHPS database at Westat, WESTAT.com, and phone number 888-808-7108. Thank you. And now I'll turn things over to Stephen.
Thank you, Teresa. Hello, everyone. I'm Stephen Martino. As Dale mentioned, I'm a senior behavioral scientist at RAND and a lead investigator on the CAHPS narrative research team. I'll be telling you about the Child HCAHPS narrative item set, which is a new resource that's available for use in connection with the Child HCAHPS survey. Next slide, please. I'll start by saying a little about the rationale for gathering narrative responses on a CAHPS survey. Research by members of the CAHPS Consortium and others has shown that narratives provide valuable information about patients' experiences with care beyond information gathered through the closed-ended survey questions. Narratives often provide additional detail about topics that are already measured by CAHPS closed-ended questions. For example, in their narrative, a respondent may describe precisely what a nurse did to demonstrate that they were listening carefully to the patient. We refer to this type of information here as integral. Narratives also often provide information about topics that are entirely outside the realm of what is covered by closed-ended items. We refer to this as distal information. And they sometimes provide information that can be thought of as extending a category that's covered by closed-ended items, which we refer to as proximal information. Research has also shown that you get considerably more of this valuable information if you elicit narratives in a thoughtful way. By that, I mean asking survey questions in a series of questions that are intentionally ordered and that walk people through the process of telling a story of their experience with getting care. CAHPS narrative item sets do just that. These item sets were developed for the CAHPS Clinician and Group Survey, the CAHPS Health Plan Survey, and now the Child HCAHPS Survey. Next slide, please. Here you can see the 5 items that are included in the Child HCAHPS narrative item set. Respondents are first asked to explain in detail what went well and what they wish had gone differently during their child's hospital stay. They're also encouraged to say how it affected them emotionally. Respondents are then asked to describe their and their child's interactions with hospital staff and how they got along. Finally, respondents are asked to say how hospital staff worked together and shared information with each other. This final question is included to encourage people to talk about care coordination, an aspect of care that's especially important in the child hospitalization context. Next slide, please. Here you can see the steps that were taken to develop the Child HCAHPS narrative item set. The process we followed is the same process that has been used to develop all CAHPS narrative item sets. We began by drafting an initial set of items and pilot testing those items to make sure that respondents understood the items as we intended, and that their responses mentioned aspects of care that we know are important in this context. Incidentally, the pilot testing phase is where we learned that we needed to add an item on care coordination. We also gathered input from pediatricians, other staff at children's hospitals, and both English and Spanish-speaking parents who were members of a parent-family advisory council at a large urban children's hospital. Once we had a revised item set based on the pilot test and stakeholder feedback, we conducted a study to evaluate the validity of the item set for measuring experiences with care in this context. The study involved 163 parents who had a child hospitalized in the past year. These parents were recruited from a national online panel. All participating parents completed, either by phone or online, a shortened version of the Child HCAHPS survey with the Child HCAHPS narrative item set included at the end. A subset of these parents also completed an hour-long interview approximately 2 weeks after completing the survey. In the interview, we asked parents for an in-depth accounting of their experiences in the hospital. The aims of this evaluation study were to assess the scope of experiences reported by parents in their narratives, the balance of positive and negative experiences described in the narrative, the actionability of the narrative feedback, and the match between narrative and interview content, which is our gold standard measure of the validity of the item set. Following the evaluation study, we made some further adjustments to the item set, and we then conducted cognitive testing of the revised item set in English and Spanish. Lastly, we conducted a field test at a large urban children's hospital in which we administered by mail one of two versions of the full Child HCAHPS survey. One version of the survey contained the Child HCAHPS narrative item set at the end. The other version contained a single open-ended item that's standardly included at the end of the Child HCAHPS survey. That item asks respondents whether they have anything else to say about the care their child received. The aims of the field test were to evaluate participation rates and item completion rates in this more naturalistic context, and to compare responses to the narrative item set with responses to the single item, the single open-ended item. Next slide, please. Here you can see some of the results of the evaluation study, including the time it took people to complete the narrative item set and the average length of narratives. About 2/3 of narrative content was positive, a little more than that when provided online, and a little less than that when provided by phone. About 8 in 10 narratives mentioned topics covered by the closed-ended items on the Child HCAHPS survey. 9 in 10 mentioned topics not covered by those items. On average, narratives included 1 or 2 actionable pieces of information, which means that they provided enough concrete detail that a quality improvement team could either address a problem that was discussed or draw a generalizable lesson from an exemplary experience. Finally, you can see that, not surprisingly, narratives gathered by phone were longer than ones gathered online and contained more codable content. The content of narratives gathered by phone also corresponded more closely to the content from the long interviews. But regardless of modality, we observed a high degree of correspondence, which suggests that the item set is a valid measure of patient and family experiences in this context. Next slide, please. Here you can see some of the results of the field study. Participation and item completion rates were high in this naturalistic context. 2/3 of parents who completed a survey that included the narrative item set provided a response to at least one item in the set. More than half completed 2/3 or more of the items. Compared to parents who completed the single open-ended item, parents who completed the narrative item set wrote narratives that were 5 times longer, contained less positive content, were slightly more likely to mention topics that were not covered by the closed-ended items on the survey, and contained more actionable content. Next slide, please. Here is an example response from a participant in the evaluation study. So in the response to the question, what went well, this person said, when we first arrived at the hospital, my son was in a lot of pain and very scared, but the emergency physician calmed him down and quickly alleviated his pain. He actually had him smiling by telling him some of the worst jokes in creation. Now that guy was made for the job. In response to the question on what you wish went differently, this person said, my son is allergic to aspirin and the attending physician did not pay attention to the records and was about to issue my child something that contained aspirin. I was truly seething with anger. They then told us, my provider made dealing with the hospital very easy. Other than the one doctor, it was fine. Nurses got along well with my son, and he also enjoyed his time with them. The provider swooped in and got information and was gone. And then lastly, in response to the question about care coordination, this person said, providers all seemed the same, quick in, quick out. The staff did a stand-up job, except one physician. So we chose this narrative because it's about average length for narratives that were written online. It contains a mix of positive and negative feedback, and it has about an average amount of actionable content. You can see in response to the second question that the parents told us something that is particularly useful for identifying a patient-reported safety issue. This is not something commonly seen in a narrative response, but it's noteworthy nonetheless. Next slide, please. Finally, here is some information about resources for learning more about the Child HCAHPS narrative item set.
You can access English and Spanish versions of the Child HCAHPS narrative item set at www.ahrq.gov/CAHPS/items-suppl/child-HCAHPS/survey.html.
You can also get access to a user guide that discusses important topics, such as how to invite responses to the item set, response mode, anonymity, and other topics.
You can access the user guide at www.ahrq.gov/administering-child-HCAHPS-narrative-items.pdf.
The two journal articles that are listed at the bottom of this slide provide more detail on the evaluation study, which I led, and the field study, which was led by Denise Quigley, who is also at RAND. Now I'll turn things back to Dale Schaller, who will lead the question and answer part of the presentation.
Okay, great. Thanks so much, Stephen, and also Teresa and Sarah and Jonathan. It's a very content-rich set of presentations, and we will now sort of move to some questions that have come in. We'll do our best to field all of them as time allows. So I'm going to first go back to your presentation, Sarah. There was a question regarding what was the comparison data that was used in your case study number 1 for determining the percentile rank?
Yes, so it was the survey vendors' data. That's what they were using, that hospital. As it happened, they do list it in the paper. It was NRC Health,
Okay.
but it was they used their own survey vendor data.
Got it. Thank you. And then Teresa, there's a question regarding the kinds of research questions. Actually, Teresa and Sarah, both of you might want to sort of address this. But Teresa, first of all, typically what kind of research questions have been posed that can be answered by the CAHPS Child HCAHPS database?
Approved research purposes, those usually include dissertations, some of the questions, anything, for quality improvement efforts and white papers.
Okay.
And I guess I would add, and I'm sure Stephen could also add, I think from a health services research lens, there's the more robust the database becomes, the more powerful it becomes for us to be able to do both quantitative and qualitative analyses. If in particular, as people are using some of the narrative items that Stephen had referenced, in addition to the general narrative item that's already a part of the Child HCAHPS survey, it really will allow us to do actually pretty potentially robust analyses, that could answer a number of questions, looking at key drivers, looking at ways for which patient experience differs based on different sociodemographic characteristics of the patients, potentially linking data to other data sets like they have done on the adult HCAHPS survey. So I think there's a number of research questions that could be answered.
And I will just add that there is the potential within the CAHPS database for Child HCAHPS to do some linkage within the data use agreement, there are some addendums that would allow a submitter to provide access to their identified data should they choose to do so. That's just an option. But as you say, Sarah and Teresa, as the content and the volume of data grows in this database, the opportunities for doing that kind of research and that kind of linkage will also grow as well.
Yeah, and just to clarify too, the narratives currently are not in the database, but once again, as this database grows, as more people use it, there's more ability potentially to be able to grow the database to become even more robust.
Exactly. So let me move to a couple of questions that have come in regarding response rates. And I'm just curious to know, Sarah, if you can address in general, what are response rates for the Child HCAHPS survey currently? And then Teresa, if you have any comments on what we've received thus far in the CAHPS database.
Sure. I mean, once again, I can't, Child HCAHPS, is not publicly reported, sort of response rates do vary. What I would say is I think that they generally are in line across multiple different hospitals and vendors. That said, I would say that there are some innovative approaches to increasing response rates, particularly understanding that parents are often in that young adult phase for which response rates tend to be low across the board in regards to survey responses. In particular, one example I can provide is we did do a study that looked at administering all but the discharge questions on the day of discharge using sort of an iPad. And we were able to do that study, that tablet study, and demonstrate that we were able to increase our response rates to sort of 70%, and overall increase the representativeness. So the patients that responded much more reflected the actual patients who had been discharged at that time. So I think there are some really innovative approaches that we can take to increase response rates. And so I'm really excited about future work we can do in this area.
Great, that's great. So Stephen, I wanted to ask you a couple of questions came in during the registration period that address the narrative item set, and one has to do with whether all 5 questions that you outlined need to be answered, or whether you can select a subset if you didn't want to ask all 5.
Thanks, Dale. So the Child HCAHPS narrative item set is it's a supplemental item set for a non-mandated survey. So of course you don't have to ask all 5 questions, but we strongly recommend that you do. As I alluded to in my presentation, the item sets work as well as they do at capturing people's experiences because they walk people through a process of telling a story that will resonate with the people who read the narratives. If you pick a subset of the items, there's no guarantee that you'll be capturing all of the important aspects of people's experiences.
Okay. Teresa, I want to go to a question regarding the kinds of benchmarks currently available. And even though it's a small number of hospitals thus far in the second year of the database, are those benchmarks available? And I believe they are. Can you just address how they can be accessed?
I think if you go to the chart book, and that can be found on the AHRQ site, that's www.ahrq.gov, CAHPS, and you look at the chart book, that will show you all of the aggregated data.
Okay. Teresa, as long as we've got you answering questions, let me ask you, there's a question here about the value of submitting data to the CAHPS database when this particular hospital can already receive sort of comparative reports from their vendor. What would be a rationale for submission to the database as well?
Our private feedback reports from the Child HCAHPS database, those can provide a helpful complement to reports that hospitals are already receiving from their vendor. So for example, comparisons shown in the Child HCAHPS database feedback reports, those might be based on a larger number of hospitals than perhaps a vendor would have.
Okay, great. So it's additive to it.
Mm-hmm.
And Sarah mentioned too at the top that there is a feature or quality of the database that allows for case mix adjustment. And can you elaborate on that?
The database feedback reports, those will be case mix adjusted in the future, and those are to account for differences in respondent characteristics that might affect the survey scores. So that would include, variables would include age of parent, guardian, education of parent, guardian, and self-reported health status of the child.
Great. One more question before I go back to you, Stephen. You were describing, Teresa, the respondent characteristics that are included in the chart book. How were the respondent characteristics for the parent obtained, which really addresses how the survey is constructed?
I'm sorry. So the parent or guardian was the person that filled the survey out?
Right. So when the survey questionnaire is submitted to the database, that information is contained and is included in all the calculations that go into reporting the results of the database, right?
Yeah, Dale, I think what you're suggesting, just like every CAHPS survey, what's wonderful is that every question you would need, not only for case mix adjustment, but also for doing meaningful analyses on the sort of different either respondent, in our case, and patient level characteristics are already in the survey itself. So
Exactly.
all of that information is included and should be in the database.
Right, exactly. Stephen, there's a question regarding the narrative item set. Can that be fielded on its own, or does it have to be attached to the Child HCAHPS survey or another closed-ended survey?
Well, there are certainly advantages to fielding the item set as part of the survey. For one thing, you ensure that you're getting narrative data from a representative sample of patients, provided that people don't selectively skip out of answering the narrative questions. In addition, you get the opportunity to interpret and understand narrative responses in the context of responses to the CAHPS composites and single item measures, and vice versa. That said, I can easily imagine a scenario where a hospital uses the item set apart from the survey. For example, if they wanted to get detailed feedback from a smaller sample of patients in between administrations of the survey, and they could do that either periodically or on an ongoing basis.
Right. Just a quick follow-on question that just came in regarding the placement of the narrative items in the context of the overall survey questionnaire. Where are they best placed?
We typically recommend placing them at the end of the survey so that people's in responding to the narrative items don't then respond to the close-ended items in a way that's differently than they might have, particularly for the purpose of trending responses to the close-ended items over time. But you don't necessarily have to do it that way. And in fact, we found in studies of narrative item sets that placing the items at the beginning of the survey sometimes encourages more thoughtful responses to the close-ended items.
Okay, great. Teresa, one last question for you in terms of submission to the database. The question has to do with, is there a minimum number of surveys that a hospital has to collect in order to submit?
Yes, currently we have set the minimum number of surveys low at 10, and that's in order to be as inclusive as possible.
Okay. Well, we only have a few minutes left, and I want to make sure we wrap up with a few sort of concluding slides. If you could go to the next slide, please. To answer your questions, not only today, but on an ongoing basis, we really encourage you to sign up for updates. It's easy to do that by going to the CAHPS website, and you look for the email update icon in the upper right-hand corner. You can see it's sort of shown on the screen here. You select that and you can enter your information to receive really valuable information about database submission periods, new webcasts that are forthcoming, and other research findings that are being sort of produced by the CAHPS Consortium. So we encourage you to do that to stay current with what we're doing in the CAHPS program. Next slide. So again, we are really pleased and welcome your questions or comments on an ongoing basis, and they can be sent a number of ways: by email at the CAHPS1@westat.com address, through the toll-free hotline, which is 1-800-492-9261. And the resources that Teresa described and that Stephen related with respect to the narrative item set and others are available on the CAHPS website, which is at www.ahrq.gov/CAHPS, CAHPS. Final slide is to thank you for attending today. Again, our speakers, John, Sara, Teresa, and Stephen, this wonderful amount of information that we were able to cover. And when you exit the webcast today, you'll be sent to an evaluation form, and we really ask you to do that. This is all about quality improvement, not only in terms of patient experience, but the kinds of offerings that we do through the CAHPS user network, such as webcasts like this. So with that, thanks again for your participation, and wish you not only a wonderful rest of the day, but a very happy holiday season. Thanks so much.